Hi, everybody. I'm Dr. Ellie Campbell. I'm a board certified family physician, double boarded in integrative and holistic medicine, and I am honored today to have been asked to speak to the Canadian Association of Clinical Thermography about 6 secrets from integrative medicine to reduce the risk of cardiovascular disease. These are our objectives for today. There are 6, and they're kind of complicated. So it's going to be a rapid ride through the cardiovascular system. We're going to talk about how genes, especially interleukin 6, methylene tetrahydrofolate reductase, and apolipoprotein E, are relevant to cardiovascular disease progression. We're going to learn which CVD prevention diet is best. We're going to talk about some key differences between the statin drugs and which may be appropriate in certain clinical situations. We're going to learn that LDL is not really associated with cardiovascular disease, but we're going to learn which lipid markers are. We're going to learn the huge role that oral health plays in cardiovascular disease prevention, and then we're going to talk about therapeutic lifestyle changes because they trump everything else. So another way to think about this is the acronym DDS LOL, because these objectives are easy to remember. We're going to talk about DNA genes, diets that matter, statins that aren't equal, lipid myths, oral health, and lifestyle. So let's get started. So first of all, we have to know that the last few years have created a paradigm shift in our understanding of cardiovascular disease. The old view was pretty much that clogged arteries looked like clogged pipes, that they were full of gunk and goo, mostly cholesterol, and that clogged the arteries. And we now know that that's not true at all, and that in fact, the atherosclerotic plaque is the progressive orchestration of oxidized LDL or corrupted cholesterol, along with inflammatory markers that make a thickening of the arteries, 99% of which is behind the drywall before it ever obstructs the blood flow. So we're missing it as clinicians, and shame on us, because cardiovascular disease remains the #1 killer in our country, accounting for 50% of all deaths at a cost of $315 billion. And the last time they published this data was 2010. Our ability to predict who is at risk has been limited and flawed, since up to 62% of all patients with heart attacks have 0 or 1 risk factor at the time of their event. 0 or 1 risk factors. We didn't know they were at risk and they had an event. Most heart attacks are caused by non-obstructing plaque. 68% of heart attacks happen in vessels with 50% or less plaque. And it boils my blood when a patient comes back from the cath lab and said, "Oh, my doctor said I was going to be fine. I only had a little bit of plaque. I only had a little bit of disease. It was less than 50% blockage, so it wasn't bad." Well, it's not obstruction. It's the rupture of these risky plaques that cause the events. A little bit of plaque is a lot of risk, because soft, unstable plaque is the plaque that ruptures. And we need to get rid of the inflammation, or you are remaining at risk. So let's get into my secrets. Secret number 1, diet matters. Virtually all of my patients get genetic testing for the MTHFR and ApoE genes, and some of them get tested for interleukin 6. So what's interleukin 6? Interleukin 6 is a cytokine. Many of us never had the word cytokine in our vocabulary before COVID, and now we know this thing called cytokine storm. Well, cytokines are nothing more than chemical messengers. Some of them cause inflammation, some of them reduce inflammation, but IL-6 is a pro-inflammatory cytokine. And people who have the genetic mutation of this particular cytokine make a lot more IL-6 from just a little bit of bacteria than people who don't have the mutation. So if you have this mutation, you're at greater risk for a cardiovascular event if you have periodontal disease and inflammatory mouth bacteria. The next gene that I test for is MTHFR. This is the rate-limiting enzyme in the methylation pathway encoded by the MTHFR gene. There's 2 polymorphisms. One's called C677T, the other's A1298C, and either wild type or we are all either wild type or some SNP variation of these 2 alleles. So the C677T homozygous, where you have 2 copies of that, is about 10% of the population. And these people are at risk for blood clots. That results in cardiovascular disease, neural tube defects in babies, pregnancy loss, Alzheimer's, colon cancer, leukemia, depression, and autism. So it's a bad actor if you get it. But if you understand the methylation pathway, which I'll ask you to memorize and repeat to me at the end of the conference, not really, Just want to show you it's a couple of cogs in a wheel. And if they get stuck, we're going to have a hard time converting homocysteine to methionine, so our homocysteine levels will go up. So methylation matters, and I test my patients not only for the MTHFR, but for their homocysteine levels. And we want to try to get our level up into the 7 to 10 range. And if you have this mutation, we simply give you B vitamins that have already been methylated. And then you don't have to worry if the gene works or if it doesn't, because we can overcome it simply by supplementation. Another gene that we worried about is called the ApoE gene. And part of the reason why this is important is because it affects which diet we recommend and whether or not the patient's allowed to drink alcohol. So apolipoprotein E is found in these chylomicrons, these little fat globules that float through your bloodstream and are produced by your liver, white blood cells, and brain cells. And they help break down the lipids. So we have to know our ApoE status because just like MTHFR has 2, ApoE has 3 different polymorphisms. If you have an ApoE2, that's protective. You get less cardiovascular disease and less dementia than people who don't have the gene. But 80% of us, including me, are the 3-3. We're neutral. We're neither at high or low risk. But 14% of the population has this ApoE4 gene. These are disease associated. And if you are unlucky enough to get an ApoE4 from mom and an ApoE4 from dad, you are 15 times more likely to get disease, especially Alzheimer's and cardiovascular disease. So secret number 2, your diet matters. You are what you eat. If you eat the FDA food pyramid, you're going to look like the FDA food pyramid. Food is actually information. It affects the expression of genes and it changes our cellular receptors. If you put junk in, you're going to get junk out. Diet is a leading contributor to at least 4 of the 6 top causes of death. And we have been told for a long time to choose the best diet for us. We want one that's going to cause optimal, vibrant health and optimal well-being, lead to a long life with easy to manage weight, and one that prevents and maybe even reverses cardiovascular disease. The problem is it's really hard to dig through all the diet. Diet books are abundant. All the research, the diet books are abundant. We have these paleo diets and Mediterranean diets and keto diets and veto diets and zone diets. How do you know? Well, these diet books are for marketing. They're really not particularly good when you're talking about science for the individual because diets are as unique as fingerprints. And the right diet for you is probably not the right diet for me. But there are some generalities that are true for most people. And if we dig through the evidence to figure out what's the best diet plan specifically for cardiovascular health, there is one clear winner. And there's a close, well, not that close, a second runner-up. So when we do a literature review of all the popular diets published in American Family Physician, one clear winner comes up. We know that all of these diets affect some of the data. We're talking about LDL cholesterol, that's low density lipoprotein, HDL, the high density lipoprotein, triglycerides, cardiovascular events, and body mass index. So all diets, some people lose some weight and change their lipid markers. But when we compare the very low carbohydrate, one with a low glycemic index, one that's low fat, so low carb or low fat, the American Heart Association diet, and the Mediterranean diet, drum roll, please. The winner is Mediterranean diet. Despite the fact that it makes minimal changes in the LDL cholesterol, the Mediterranean diet decreases cardiovascular events with grade A evidence. So that's the highest, best evidence that a doctor can get. But what, after all, is a Mediterranean diet? After all, the French don't eat the same as the Italian, who don't eat the same as the Greeks or the Turks or the Lebanese or the Moroccans, but they're all on the Mediterranean Sea. So what, pray tell, is a Mediterranean diet? Well, these are the basic rules. Your Mediterranean diet is abundant in plant foods. The dessert is typically fresh fruit. Olive oil is your principal source of fat. Dairy products are consumed in low to moderate amounts, with eggs consumed only weekly, red meat extremely rarely, less than 1 meal per week. Wine, however, is consumed in low to moderate amounts on a daily basis, and the total amount of fat is relatively high, 25 to 35% of the calories, but not a lot of saturated fat, which is less than 8%. So olive oil is their primary source, and it's very high in monounsaturated fats. So in general, the Mediterranean diet, you're going to score a 9-point score with above 1 being beneficial. And so beneficial things, you have to have vegetables and beans, fruits and nuts, whole grain cereals, fish, and a little bit of alcohol. That's 2 drinks for men and 1 for a woman. But you should not be having red meat, poultry less than a couple times a week, dairy less than a couple times a week, and red meat less than once a week. If you do those things, if you adhere to the Mediterranean diet, and you're one of these 22,000 Greeks who were studied for 44 months, we found that heart disease happened 66% as often. Cancer, 75% less than the people who ate the regular diet. And total mortality, 75% less. So you can improve your lifespan, not get cancer, and not have a heart attack simply by following a Mediterranean diet. In the Hale study, it saved lives even if you were old. If you started this diet at age 70 to 90 years old, you still had a 50% lower all-cause and cause-specific mortality. The Mediterranean diet splits out big time, and it says there's a 70% reduction in cardiovascular mortality without heart attacks and the secondary endpoints independent of blood pressure or lipid changes. So even if your blood pressure doesn't change, even if your cholesterol doesn't change, you still do better on the Mediterranean diet. So the clear winner up with between 22 and 85% reduction in cardiovascular events and death is the Mediterranean diet. Who was our second runner-up? Turns out it's the Dean Ornish plan. The Dean Ornish plan, however, is an integrative lifestyle plan of 10% fat, very low fat compared to the Mediterranean, whole foods, vegetarian, combined with aerobic exercise, stress management, smoking cessation, and group classes for psychological support, and they did it for 5 years. So it's really hard to tease out what effect was the diet and what was everything else. However, it was proven that they not only prevented cardiovascular disease from getting worse, they actually reversed it and thinned out the plaque that was seen in the arteries on the catheterization. So that's amazing. So this is the Mediterranean diet for everybody. This is what it looks like. A little bit of salt, exercise, wine every day, a few times a week, white meat, including poultry, and only a few times a month, red meat. So who shouldn't eat the Mediterranean diet? Unfortunately, those ApoE44 people that we talked about earlier, they should not eat a Mediterranean diet because this low-fat diet is the only one that helps. If they eat this high-fat Mediterranean diet, they worsen their lipid profiles. They worsen their cardiovascular events. They have to be on a 10% low-fat diet. Unfortunately, also, alcohol is terrible for their brains. It actually worsens their memory and cognitive scores. So if you carry ApoE44, we tell you no alcohol at all. The rest of us, 1 or 2 drinks a day. All right, so what's my secret number 3? Statin drugs are poison. We have to use them sometimes, but we have to respect them. What are they? Lipitor is the most common. Crestor is another that some people take. Pravastatin, simvastatin are others. So what they do is they block this rate-limiting step from acetoacetyl-CoA to mevalonic acid. Through this pathway, they block this enzyme. And unfortunately, that is the rate-limiting step that causes cholesterol to go down as well as CoQ10 to go down. So cholesterol does never go to zero, right? We never stop making cholesterol. We just reduce the amount. The same happens to coenzyme Q10. Well, coenzyme Q10 is an amazing antioxidant. And so without this, you live in a state of higher oxidative stress and higher inflammation. CoQ10 naturally drops as we age in our heart, in our kidneys, in our lungs, and in our liver. And if we're going to be starting these cholesterol medicines down here at age 40, 50, or 60, we're already at a deficit for CoQ10, and we have to be taking this as a supplement if we're going to be taking statin drugs to lower our lipids. So they're the angel and the devil in the same pill. Statin drugs do decrease oxidative stress. They do decrease platelet stickiness and blood clots. They do decrease white blood cells sticking to endothelium. And for this reason, it looks like they may have a survivor benefit in the COVID infection. Statins do decrease the likelihood of plaque rupture. That's huge. They decrease mortality, and they probably decrease Alzheimer's disease, and they decrease tooth loss, believe it or not. However, they increase muscle disease, liver toxicity, might increase the risk of diabetes, might be hard on our kidneys, possibly increase stroke, but that's the atorvastatin study we'll talk about in a minute. And then they do increase plaque in the coronary arteries. Calcium in the coronary arteries. Now, this may not be a bad thing because the calcium actually calcium hardens the soft plaque. I told you earlier, soft plaque ruptures and causes events. So when it's calcified, it's more stable and less likely to cause disease. But it looks like the disease is advancing when you do tests that measure calcium. Oh my gosh, they started statin and their calcium got 4 times worse. But that meant they had a lot of unstable and risky disease, and now it's not so risky. So this other gene called KIF6 encodes for a protein inside the cell that determines your cardiovascular risk, about a 35% increase in women and 50% increase in men. And this gene is going to predict if you're going to react or respond to the currently available drugs that we have. So without going into the details, because we don't really have time, if you have this genetic mutation, Lipitor and pravastatin are not going to work. And this may explain why in the studies, 33% of all heart attacks and 25% of all strokes happened in people who were taking the drugs, probably because they had the gene that said those drugs weren't going to work, but the doctors didn't know that yet, so they didn't know who to choose and who not to choose. So they had strokes even though they thought they were going to be prevented. They had heart attacks even though they thought we were going to be prevented because we chose the wrong medicine for their genotype. So if you don't test KIF6 and you don't know the status, ask your doctor to put you on atorvastatin or pravastatin. Avoid atorvastatin and pravastatin. The better choice is rosuvastatin or simvastatin. Almost all my patients get Crestor. That's rosuvastatin because I don't typically test KIF6. It costs a lot of money, and I just put them on a different medicine. So secret number 4, cholesterol is good for you. We came out a couple years ago, FDA said, we were wrong. All those years we were vilifying cholesterol. We told you it's bad for you. We were wrong. It's not. Dietary cholesterol, how much you eat does not change your blood cholesterol levels. Egg eaters unite. Go ahead and have 1 to 4 eggs a week. They're good for you. Serum cholesterol is not bad for you. In fact, the higher the cholesterol was, the higher your cholesterol was, the longer you lived. So people with the highest cholesterol live to be the longest, as long as it's not corrupted. If your cholesterol is corrupted, it's a whole different story. Each 1 millimeter of higher cholesterol caused a 20% decrease in mortality. So high cholesterol is good for you, but don't let it get corrupted. Cholesterol is the grandmother of all steroid hormones. You need cholesterol to make estrogen. You need cholesterol to make progesterone. You need cholesterol to make testosterone. You need cholesterol to make vitamin D. So all these years we've been barking up the wrong tree because we've been saying LDL cholesterol is the problem. It's not. It's cholesterol that's corrupted or it's inflammation. That's where we need to be focusing. We need to stop vilifying this dang LDL. So what we need to look at is corrupted cholesterol. If it's oxidized or rusted, if it's too small, the wrong size, or if you have this widowmaker cholesterol called lipoprotein A, these are the corrupted cholesterols. We want to look for markers of inflammation on your blood work. Ask your doctor for myeloperoxidase, LP-PLA2, high sensitivity C-reactive protein, oxidized LDL, and F2 isoprostane's a urine test. If those are elevated, we know you have inflammation. And we can do a survey to screen for calcification in your blood vessels. I can do a coronary artery calcium score CAT scan. I can do an apical brachial index to look at your leg arteries. I can do a carotid intima thickness measurement of your carotids. I can do infrared thermography and see if you have inflammation in your blood vessels. I can find it on a chest x-ray, a mammogram, a plain x-ray. As clinicians, we need to be vigilant for arterial calcification. And if our patients have it, we need to start them on an aggressive prevention program so they're not one of those 68% of people that go on to have an event when we didn't think they had any risk factors. But if we were looking for these, we would know that they had more risk than we thought. None of the hundreds of cholesterol studies done to date have ever shown that LDL causes heart attacks. So, secret number 5, the mouth is connected to the heart. Oral health matters more than ever. There's a significant link of cardiovascular disease to periodontal disease. Periodontal disease bacteria cause trouble. They have these toll-like receptors that stick off the end of certain bacteria, gram-negative bacteria particularly, and these little things can act like antennas to attract cytokines. They can act like needles that literally puncture the endothelium of the artery and cause plaque rupture, triggering events. So they're bad actors. When we do an assay of coronary plaque and we are looking for this plaque behind the drywall, notice this blood hasn't changed any. There's no change in the size of the blood vessel. Blood flows normally, but there's still a bunch of plaque back here. If the patients go to bypass surgery and we cut that little chunk of artery out of their heart vessel, when we look at that plaque under the microscope, 92% of the patients with periodontal disease have the same bacteria in their coronary artery sample as they do in their mouth, versus only 20% of people who don't have it. So those bacteria from your mouth live in the plaque of your coronaries. 42 patients studied with carotid disease. They took the carotid plaque and looked at it. 100% of them had plaque from their mouth living in their carotid arteries. So since the 1970s, infrared thermography has been used as a potential screening modality for carotid artery stenosis. If you see a thermogram and it looks like this red hot blood vessel here in this patient's neck, please use that as a jump start. Get that patient evaluated for cardiovascular disease. They need blood work. They need a coronary artery scan. They need a stress test now. We find carotid artery stenosis and inflammation up to 57 to 93% of the time on thermography when we see it other ways. So it's a good screening tool. Periodontal bacteria, we talked about, live in this thrombus that cause the blood clot, right? So not only do they live in the plaque, they live in this blood clot. And this is a really interesting study that Dr. Pesce did, because they took patients who were in the ICU having heart attacks, 100 of them, and 30 of them consented to have a panoramic tomography CAT scan of their face, of their teeth, while they were having a heart attack. And 30 of these patients had asymptomatic abscesses in their teeth, no symptoms whatsoever. But when they dug into it, the mouth bacteria, 72% of these blood clots had mouth bacteria. So many people having a heart attack, the reason is they're having a tooth abscess and they didn't even know it. So you can test for these periodontal bacteria. This is a spit test I do in my office. This is the first test they did, lots of mouth bacteria. This is a follow-up test after aggressive treatment. So you can clear up that mouth bacteria and ideally reduce the risk. Looks like that. Swish saline in your mouth, spit it into the cone, put it in the test tube, ship it off to the lab. We love our dentists because no cardiovascular risk reduction program is complete without an experienced dentist and hygienist on the team. But secret number 6 for today is that lifestyle trumps all. It's time for a paradigm shift in our care model. Our current crisis management approach to taking care of heart attacks in the ICU is no longer sustainable. It's too expensive. It's going to bankrupt our system. It's time we shift from looking at the lumen where the blood flows to the health of the artery. Primary care doctors think that the cardiologists are managing prevention, and cardiologists think the primary care doctors are. And I know because I've asked us. I've asked my primary care doctor, if you send a patient to a cardiologist, who's doing prevention? Oh, they are. That's why I send with the cardiologist. And the cardiologists say, oh no, that's the job of the primary care doctor. They get their toes stomped on if we do any primary prevention. We're just here to do the procedures. So there's a disconnect in communication, and we all have to put more resources into prevention because prevention works. Primary prevention prevents the plaque from ever forming back here. Secondary prevents this plaque from rupturing. Tertiary is somebody who's already had an event, and now we're going to prevent them from having another one. But I do all 3 in my office, and I think more doctors need to. The American Heart Association has outlined 7 essentials for heart health. They're pretty simple. It doesn't sound that hard. Don't smoke. At every visit, we should be asking, advising, and assisting their patients in how to quit smoking. They should not be overweight, body mass index less than 25. Do exercise, which is typically defined as 30 minutes, 5 days a week. But it turns out if it's high intensity interval exercise, it only has to be 12 minutes a day. Get your total cholesterol below 200, your blood pressure below 120/80, your fasting sugar below 100, and follow 4 of these 5 DASH diet. 4 to 5 cups of fruits and veggies a day, 2 to 3 ounces of fish per week, 3 12-ounce sugar-sweetened beverages or fewer per week, 3 1-ounce servings of fiber or more per day, and less than 1,500 milligrams of salt. If you follow those, the 7 essentials, and you take 6 out of 7 of them compared to people who don't do any of them, you will have 10 times less heart attacks, 88% less death, 70% less heart failure, 60% less cardiac dysfunction seen on echocardiogram, 90% less diabetes, no chance of having kidney failure, 37% dementia, and 51% less cancer. So the lifestyle manifestations, these lifestyle prevention things, trump my drugs by 10-fold, 20-fold, 100-fold better with lifestyle prevention than anything I can do with my drugs. For women between age 27 and 44, if you don't smoke, have a normal body index, exercise, don't watch a lot of TV, and stay in the top 40% of healthy diet without too much alcohol, you can have 92% less risk of heart attack. So lifestyle changes trump everything else for cardiovascular prevention. And these are in our power. We don't have to relinquish this to our healthcare professionals. This is our job. So we did it. We got through our 6 DDS LOL. We talked about how your genes matter. Your prescription should respect your genetic individuality. The diet matters, Mediterranean for most, but not if you have ApoE4. Statins are poison, but necessary. They're not all equal, and if you don't know your genetic status, you should probably be choosing rosuvastatin. Cholesterol is good. Cholesterol that is corrupted is not good. Oral health matters. Look for and treat periodontal disease and have a high index of suspicion for root canal disease and abscesses. And lifestyle trumps all other interventions. So thank you for your time. I appreciate it. I hope you learned a few things today. Please keep in touch. info.cfm@gmail.com is my practice email. We'd love to hear from you. If we can give you any more information about anything you heard today, we're happy to share with you. My website is campbellfamilymedicine.com. Please like us on Facebook and watch for my book coming out in Q1 of 2021 about the ways the mouth is connected to the rest of the body. I'd like to teach you a lot more about that, more ways than you could ever imagine. So I'm Dr. Ellie Campbell. Thank you for your time.
The Canadian Association of Clinical Thermography is dedicated to making thermography more accessible and available to those who seek it. Become a supporting member today and help us transform the way medical thermography is understood in our world by practitioners and the general public. Visit us today and join us.